We are live. So many different microphones to choose from here. Let me go up here. All right, welcome everyone to our breakout session for S2108. I'm actually going to go to this microphone. So this is a little bit of a new experience for all of us, I think, because it is a truly hybrid meeting. As one might expect, we actually have more participants online than in person. So I think people are still coming in. So I think what we might want to do is, since it is still a relatively small group, why don't we just have, actually, I think we should do some quick introductions and get started that way. And that way we can also, everyone can also test their microphone. We'll start with the room. So my name is Jens Rüter. I'm the one of the two co-chairs, one of the study chairs as listed on this opening slide. I am a medical oncologist by background, and I am also the medical director and chief medical officer of the Jackson Lab, which is a biomedical nonprofit research organization. And I think most of you have heard me talk about the study before. In fact, many of on this call are actually part of the study team. So why don't we just do some quick introductions? So maybe we can have the folks in the room, can you just go up to the microphone and just say who you are? Would that be okay?
I'm Alex Wilson. I'm the CCD-RPI for the Columbus and Coronal Radiation Oncologist.
Great. Nice to meet you in person. We've, it's hard to recognize people with with masks on. Yes.
Hi, I'm Amanda Stampless. I am the plain language medical writer at SWOG. Just started back in January, and the plain language summary for this study is in progress. So that's why I stopped in this session today.
Thank you so much. And then we have.
And I'm Diane Liggett, and I am the SWOG data coordinator for this study.
Great, thank you. All right, and then we'll just quickly go through the folks on the call. We actually have now 24 participants, so the number is going up. So this may become a little bit difficult, but why don't we go through at least the study team? So Meghna, do you want to just introduce yourself?
Sure. Sorry, turning on my camera. Hi, everyone. Meghna Trivedi. I am the co-chair with Jens on this study. I'm glad Jens could make it in person. I'm attending virtually. I'm a medical oncologist at Columbia University, and I look forward to talking about this study with everyone.
Thanks, Meghna. I saw Emily. Emily, you want to go next?
Hi, I'm Emily Edelman. I'm the Director of Clinical Education at the Jackson Laboratory. I'm a genetic counselor and genetics educator, and excited to be collaborating on the education development and implementation as part of this program.
Thank you. And I think Kate Reed, are you also on?
Yes, I'm here. So I'm Kate Reed. I work with Emily in the clinical education department at Jax, and am very excited for this study.
Great. And then we have Leah Graham.
Hey everyone, I'm Leah Graham. I'm the Associate Director for the Maine Cancer Genomics Initiative. So I work with Jens and I work with Kate and Emily at Jax. And it's great to be here. Thank you all for attending.
Thank you. And then I definitely saw Katie Arnold. Do you want to just introduce yourself?
So, hi, my name is Katie Arnold. I'm one of the statisticians working on this very exciting study.
Thank you. And I think I saw Dr. Symington on as well. Banu, you want to introduce yourself?
Yes, hi, I'm Banu Symington. I'm a medical oncologist in an extreme rural practice in Wyoming, bringing the rural perspective to this, the boots on the ground rural perspective to this.
Thank you, that's great. And then we have, I think Sarah, yeah, Sarah's there as well. Sarah, you want to introduce yourself?
Hi, I'm Sarah. I'm one of the statisticians working with Katie and Joe.
Great. And I saw Joe here earlier on, but I don't see him in the room yet. Let me just make sure that is anyone else from the study team on the call? It's a little hard to tell for me, but I think I've covered everyone that's on the slide. Okay, So what we thought we would do today is basically provide a bit more detail and depth about the study itself, some of the study operations, and more practical aspects, and also answer your questions if you have any. So we will, before we get started, though, I wanted to also thank, of course, everyone else that's on this slide that we didn't introduce for helping work this through, Diane, and there are many others that are involved, as can be mentioned here, especially, of course, Dr. Hirschman and Dr. Ramsey, and then also Joe Unger have really all done a great job so far in helping us put this together. Now, before we actually go directly into the protocol, I thought it would be helpful for everyone to actually talk a little bit more about what a genomic tumor board, as it currently stands, is actually all about. And just before I go into that, just a little bit more background. This project actually started when Meghna and I met here or at this meeting a few years ago and discovered that we have sort of a common interest, and that is around how genomic tumor testing is actually useful and used in the clinic. And from the JACS, from my perspective, we had, and the folks that are on the call introduce themselves as such, we have been running a program called the Maine Cancer Genomics Initiative, which is a philanthropy-funded program in Maine, where JACS has its headquarters, and also where we actually have a large rural population to really bring genomic tumor testing and genomic tumor boards to the state. So we've been running genomic tumor boards there in a basically as a service to the clinical community, and so we really thought it would be interesting to investigate this in other parts of the country, and also to really show that it does provide benefit in terms of impact on patient care decisions, and ultimately also on patient outcomes, which is of course the gold standard. So that's why we designed this cluster randomized study, where, as we will see in a minute, of course, half of the sites are then randomized to a usual care arm, and half of the sites actually get this intervention. I thought it would be useful to just kind of walk through a genomic tumor board and actually also show a quick video clip, audio video clip. It's actually a recording of a WebEx meeting that really shows what we call the secret sauces of these genomic tumor boards, where you have a genomic oncology expert kind of walk through available evidence that supports the use of a drug or not, and sort of comes up with a treatment recommendation. Let's see here. It's always the question, which is the right.
Since you've been messing around, you can click back on the presentation.
Oh, I've been messing around. Okay, that makes sense. Let me just actually use this right here. There we go. Okay, so I basically already talked about that. So in a genomic tumor board, oh, sorry, yes, I have to go back to the to the mic. So I think now it should work because I didn't mess around. So when we start these genomic tumor boards, we actually use a slide deck like this, and just ignore the fact that this is JACS branded and everything else. But we really start with a case, of course, and with a case presentation. And this is one of these typical screenshots you get from WebEx, but we basically have a slide like this that actually shows, sort of the most pertinent clinical details of the patient, including prior history, and then also some kind of what is the current, the most acute sort of issue here, which is that there's a progression. And this is obviously a very difficult to treat tumor. It's a glioblastoma. And the question is, what do you do next, right? So the patient, this particular patient, had genomic tumor testing done. It's a little bit hard to read on the screen. It might be better on the Zoom, but the bottom line is you get a list of a number of genomic variants here. I'll just take my word for it, and some immunotherapy biomarkers, and then also some other information on eligibility for trials. And basically, this is what you get from the testing company, right? So we have someone walk through this report and explain what all the alphabet soup means in terms of the different alterations. And then we go to what I would call the secret sauce, which is sort of this, which is the treatment evidence, which we then display in this kind of a fashion, where we show what actually has been looked at in terms of drugs for specific genomic variants, and what the supporting evidence is here based on the so-called AMP-ASCO-CAP guidelines. And this is taken from the knowledge base, the JACS clinical knowledge base. So it gives you already an impression of whether or not something actually has been looked at and or works. And in green, you have here sort of the sensitive data. In yellow, and in blue, you also have some sensitive data, but then in yellow, you have all the sort of quote unquote negative data. So we present all of this as a starting point for what follows next, which is basically a clinician kind of walking through the evidence.
Where we need to go with it. A lot of the trials require the V3 mutation, which this patient does not have. So there is the antibody drug conjugate that's like the second generation of the ABT414. It's ABBV321 that is currently enrolling, though I'm not sure. It looks like New York, maybe the closest, though you may have an updated view of that. And then there's some other like doxorubicin loaded EGFR targeting nanocell formulations and trials, and intraarterial cetuximab, so trying to get it in, get targeted therapy in past the blood-brain barrier in novel ways. There just isn't much to really support utilizing a oral tyrosine kinase inhibitor, and I think we've kind of moved past that in clinical trials just because of the limited benefits that have been shown. The RAD51 was interesting, though. I was focusing on the EGFR stuff and not that one, because a loss of RAD51 is part of the homologous recombination pathway, and they are looking at PARP inhibitors. The patient would not be eligible for one of the large basket trials, the Lodestar trial, but they're specifically looking for patients with RAD51 alterations in one of those two cohorts to get rucaparib. Primary gliomas, unfortunately, are excluded, but if there was another clinical trial that incorporated a PARP inhibitor, as I know that they're being looked at, in primary gliomas, that could be a consideration.
What if you could get it off label? So, is it Opartic trial used olaparib? I think there's like niraparib or something out there too. I mean, if we could get it off label, would it be worth trying it? And the other question is, would you try it with Timidar? Because I always thought PARPs work better with an alkylating agent, but she's unmethylated, so I'm not even sure if that's worth it.
Yeah, it's the single agent PARP data is, it's not as robust as we would like it. And putting it with Temidar, certainly in vitro, has shown synergistic benefit. So if she was able to tolerate that, and we have the data from the operatic trial to give us an idea of how to dose it and safety, and it's an oral option too, which is nice. And aside from blood count, hopefully would be tolerable for her given her age.
Right.
I think it would be a consideration. Now, if she only does have one loss of function, or one copy loss, rather than the biallelic loss, so that may decrease the efficacy, but I think, just given the limited options, if you were looking for something off label, it's more of an unknown.
Okay.
And, we have negative data, certainly with the EGFR TKIs. So
right.
If an EGFR TKI or an EGFR trial was not available and you wanted to try something off label, getting the olaparib and putting it together with the Temidar would be potentially biologically supported.
Okay. All right. Well, that's helpful.
All right. So that was, and I apologize. I actually realized I think the issue was the audio and the video weren't matched, and that's why there was a little bit of cut off, and you saw that it wasn't quite synchronized. But so this is kind of what happens during a genomic tumor board, and these are the kinds of you heard the clinical expert there kind of walk through the different considerations. What is known, what is not known, actually, what has worked, what has not worked, and then actually focused on one specific aberration. And these are typically the kinds of outcomes that we observe in these discussions. You can also see how having the evidence together with an interpretation is really quite helpful because it really provides a bit more context. So since this is sort of a little bit of an outlier for this entire presentation, any questions or comments on this part of it? We'll just briefly pause, otherwise I'll keep going. And let me just monitor the, yeah, it doesn't look like there's anything in the chat. And now I think I messed with it again. So let me just go back in here. All right, so this is the study schema, as you have seen in prior presentations, including the one we just had at the CCDR committee meeting. There are going to be 18, we're going to have 18 so-called recruitment centers that will then be randomized to 9 sites that get this EGTB intervention, and then 9 sites that continue under usual practice. And then the primary endpoint of the study is the proportion of patients that started on evidence-based genome-informed therapy at 6 months. So we're choosing a fairly narrow window because we feel like with the majority of the treatment decisions based on that discussion at the Genomic Tumor Board will be made within a 6-month time frame. And in here you have a few other kind of points. There is a baseline physician survey that we will use for the secondary endpoint analysis, and then there's also an end of study physician survey that will kind of help us better understand how this intervention has actually impacted some of the physician-derived endpoints. The patients are followed for up to 24 months. There are no protocol-specified treatments or visits within the study protocol itself. We'll get to some of the other data points in a minute, or the other time points of when there is an assessment. So, I already covered the background of this. I think this is really the most important part. The hypothesis here is that this GTB, which offers a combination of expert opinion, guideline-enabled summary of the available evidence, and supporting educational material, which we didn't show in this particular example, but we can get into in just a minute, will yield an increase in evidence-based genome-informed therapy in this patient population. So this is the study design, just kind of shown in a slightly different way. But basically, we have a number. So we enroll the randomization happens at the recruitment center level. And then at each recruitment center, a number of physicians will enroll a number of patients, right? And obviously, there will be a little bit of variation in that sort of quote unquote behavior. In the intervention arm, there's a GTB intervention that the physicians can or will have access to and are going to be asked to participate in. In the control arm, that doesn't happen, and we simply follow the patient's outcome as they sort of develop. As I said, the recruitment center is a unit of randomization. Physicians register within their recruitment center. The patients then register also at the recruitment center under their registered physician. And one important thing here is, and this is, we struggle with this even in our main project, the patient care in the study is not directed. There's basically, the genomic tumor boards or the EGTB intervention is an intervention because it provides additional, support. But at the end of the day, all the treatment decisions are made at the physician's discretion. And even though the board may issue a recommendation, and I'm putting this in air quotation marks, it's really at the end of the day up to the physician to then decide what to do next with the patient. So these are the primary and the secondary objectives for the study. We already covered essentially the primary objective where we want to determine whether this intervention increases the proportion of patients who receive evidence-based genome-informed therapy within 6 months after registration of the study compared to usual practice. And then there are the secondary objectives, and this explains why we're asking for the physician surveys. There are some physician-derived parameters, such as genomic confidence and physician experience with genomic tumor testing. And then, of course, we also want to compare the clinical outcomes, survival, and so forth on the study. And then also, this is also an interesting point here. We also want to assess whether or not the physician assessment of evidence-based genome-informed therapy matches up with what the central study team determines. So as you can imagine, in order to determine the primary endpoint, we as the primary study team will basically do a blinded review of all of the treatment outcomes within 6 months of enrollment, and then decide whether or not a treatment is genome informed based on algorithms which will be very clearly outlined in the protocol. The physician does not have this algorithm in front of them necessarily, so they will be, we want to see how much that kind of overlaps with the study team's determination. And it's really an exploratory endpoint, and it gets at this idea that you can, actually impact or you can, by the end of the study, we're expecting that there will be an increase in sort of that there will be, more aligned, right? Because the interpretation of the physicians would basically improve. We do have these implementation objectives as well, which are relevant if you are at one of the sites that is rolling out the study, because we do want to understand how this intervention would fit into normal clinical workflow. What are the barriers? What are the facilitators? Because, one of the next steps in this could be a larger, randomized trial. We're looking at patient survival, or, sites may decide that they actually want to implement something like this. And, it will be important to understand what actually makes it work versus what actually makes it not work. And that's the purpose of these implementation objectives. And it includes, also the evolution of GTT utilization, which is important because there is a temporal effect here as well. And over a 2-year time period, everyone's behavior may change. And we can actually already see this happening now. Up to now, the guideline recommendations, the NCCN guidelines, were fairly narrow in their focus as to who should even get genomic tumor testing done. But ASCO, for example, just came out with a statement that every patient that has stage 4 disease should really get genomic tumor testing done at some point in time in their care. So in order to make sure that we catch these types of temporal developments, we do want to assess what the evolution is of utilization within each practice. There are some stratification factors in there based on minority and underserved status. And so just a little bit more information on the intervention itself. I gave you an example in the beginning of this moderated discussion that, there wasn't much moderation going on at that meeting, but actually that was a recording from about 2 years ago. And that particular practice, there's actually quite a bit more back and forth now. And so it's important to have a moderator that can kind of, enable that and facilitate it. The overall goal here is to prioritize the potential treatment options and to provide a framework to help physicians think through the case so that you actually, I think the expert that we just heard had a very clear schema that she applied. She went through the data from existing trials. She thought about currently accruing trials, and then thought about whether or not the evidence is actually supportive of using something potentially off-label. We will provide a written summary of this discussion. We call them minutes. They will be distributed within a short period of time after the meeting itself. We expect that there will be about 4 GTBs per month. So about one per week is our current goal. We'll have various days and times of the day. And also, we obviously we will accommodate time zones and also clinical workflows. Our experience in Maine has shown that that we can really be most successful if we actually work with the practices and inquire beforehand what are some time points and some days of the week that actually would work for such a meeting. If you don't do that, then people have a hard time showing up or just don't show up. So it's very important. So this is sort of the process. The patient is registered on study, and there are some specific forms if you're enrolling the patients where we ask for specific elements of the patient's clinical history and background. The genomic tumor test results are uploaded once they are received, and then we schedule the GTB date within 2 weeks of the upload of that test report. We will have a central coordinator that is most likely going to be at JAX to, help get this all scheduled and all coordinated and everyone, kind of pulled in. During the GTB, we'll have about 4 to 6 slides to kind of walk through the case, as you just saw part of that. And then there will be this moderated discussion. It will take about 10 to 15 minutes. That's another job that the moderator has to make sure that we're kind of staying on track. We usually try to get through 4 cases per hour. If we need to do more, that's fine. We just need to know about it ahead of time and kind of plan accordingly. And then we'll provide the summary, as I said earlier. The supporting education, we have both Kate Reed and Emily Edelman here on the call that can talk more about this if there are questions, but this is also an evolving program that we have already started over the last few years. We already have a number of different modules and different topics that are currently covered, but the expectation is that more educational topics will come up over time, and they will then be developed in relatively short, with relatively short turnaround to address any sort of issues that may come up. All the resources will be available online. There will be different formats. This is a team that's excellent at making sure that the content is delivered in a way that's actually appealing and people actually want to read it and look at it and learn from it. And we also do have, most of these modules will have CME credit associated with them. So that's another benefit. And it's going to be important, of course, to have a variety of different approaches. And we've already thought about a number of them. We'll make it interesting for sure. We are planning interviews with some of the physicians, with a subset of the registered physicians. And we have currently identified 3 different time points: pre, mid, and post-study implementation, just to kind of get an idea how things change over time. We have put some parameters on this. Obviously, video conferences or televideo conferences lasting approximately 30 to 60 minutes. We'll record them and transcribe them because it's going to be research data that we want to analyze. And again, as we said earlier, the goals of these interviews are really to understand the implementation of the intervention, but also to understand the evolution of genomic tumor test utilization within each practice. Let's talk about eligibility criteria for just a minute. So for the recruitment center, we all know that NCORPs can be fairly large. Some NCORPs have multiple healthcare systems. So it's one NCORP site can have multiple recruitment centers for this study. And there are some criteria defined, as to how you can do that. Obviously, if everyone always works together and makes treatment decisions together in multidisciplinary and collaborative case conferences, for example, it's going to be very difficult to have multiple sites, multiple recruitment centers within one NCORP site. But I've actually talked to a physician a few weeks ago. I don't know if he's on the call or in the room even, when we discussed where there were 2 separate healthcare systems with separate EMRs and completely separate operations. And those could very well be 2 separate recruitment centers for this study because there is no overlap in terms of the clinical operations. It's not, I do know there are some studies actually are very much based on EMR, kind of alerts, and EMR, it's an EMR based intervention. Sharing an EMR does not mean that you cannot have 2 separate recruitment centers either. Again, it really depends more on the decision making, the patient care decision making process. And we have a recruitment center application form that's currently circulating, and thanks to those sites that actually already filled it out. It was a little bit early because we had circulated it with some folks to just to see if it actually makes sense and if everything is that we're asking is actually appropriate. But thank you anyway to the sites that have already done it. That's actually fantastic. And we will select 18 recruitment centers from the pool of applicants. And there's some more, kind of logistics here and some sort of size criteria, if you will. One thing that's also important, there must not be a prior GTB or a molecular tumor board already at the site. We have some more specific criteria in the protocol. There are some instances where it may be that you're discussing molecular findings at a regular multidisciplinary tumor board. That may actually be okay. If you have questions about this, if you would like to participate as a site or as a recruitment center in the study, and you're wondering whether or not you would be eligible based on that criterion, we're happy to talk with you about this and then sort of make a decision as to whether or not it's appropriate. That's probably the best way that we can manage this. There are, as I said, there are some, you have to have at least 10 patients per month that get these large genomic tests ordered, and that again is per recruitment center. Just another way to think about how many practices you might need to bundle together under one recruitment center. At least 4 practicing oncologists, and we basically, if you look at this list, we actually excluded radiation and surgical oncologists for the one reason that they don't typically order targeted therapies, right? That's why. That's the only reason why. If there's any scenario that you can think of where that's different, let us know, and we can certainly talk about that. And there is some sort of commitment to registering 66 patients over 2 years to the study. That's just based on the expected sort of patient enrollment that we need or would like. And then also important is for every genomic tumor board that we run that has a patient from your site or from your recruitment center, send at least one team member. Ideally, we would like the physicians to be there directly, but if that's not possible, then we need one team member there at the board. And then there are some other criteria about the willingness and the ability to document how many tests are ordered. And again, this is all about better understanding what are the general trends, and also, quite frankly, what is our denominator? If there, we want to know if there are X number of tests ordered at a practice, how many are actually being enrolled on the study, and how many are we discussing at the genomic tumor boards? Yeah.
Sorry, there's a hand raised. Judy has her hand raised. Just wanted to let her ask her question.
Yeah, that's a good idea. Thanks, Magda. Judy, you want to go ahead?
I wasn't sure I could unmute myself. So I had a question with the application, and you asked about thinking about barriers to enrollment. We have a site who have 2 medical oncologists and 2 radiation oncologists. They meet all of the other criteria as far as volume, and they're one of our more rural sites. They feel like they meet the volume, especially because they do a very large lung cancer population where they do a lot of genomic testing in that group. Would you give some thought or consideration to changing the criteria with saying there must be 4 providers so that this site and others like it could potentially be eligible? I was thinking about maybe you wanted 4 because of the attendance at the tumor boards, but I also know that the radiation oncologists there at the site and some of the other sites that I have, even though they don't order testing, are very involved in treatment planning and care, and there's a lot of chemo radiation combined. And this practice manager or the providers feel like they could have at least representation when they needed to have representation with the 2 medical oncologists, if we would allow the radiation oncologist to count as 4 or remove that 4 as a barrier.
Yeah, Judy, thanks for bringing up that question. I think we should talk offline about your specific situation. I will just say one thing, and then Magna, maybe you can also chime in. But one of the reasons why we have this sort of physician requirement is we wanted to ensure that the sites are balanced in terms of the number of physicians. But certainly, I think the volume question that you raised, or the fact that there is enough volume there, or should be enough volume there, may actually make up for that. I don't know, Magna, do you have any thoughts?
I think part of it is also a statistical issue because of the correlation. Maybe Katie or Joe could answer that better than me. I think that was one of the reasons why we needed 4 physicians from each site. Is there's also a statistical component to this, and so I think the idea is that we want treatment decision makers, so people that are making treatment decisions, because they're the ones that we think that this intervention is going to affect the most. But we can certainly, I agree with Jens, we can discuss with you offline, Judy, the exact situation there and how much involvement the radiation oncologists have in the treatment decision making that's based on the genomic testing. I think in most sites, it's usually the medical oncologist that decides the systemic therapy, but perhaps there's some variation at different sites.
Just a comment on that, Scott Ramsey. It may be due to the interclass correlation. That's the statistical test you're referring to. But I would talk to Joe to see if having one clinic with fewer than what's used for those calculations would have a material impact, because it certainly sounds like this is a good site for the study. And I know from experience how hard it is to get good sites.
Thanks, Scott. Yeah, Diane. Yeah, please go ahead.
This is actually not the question. So what I'm hearing from Judy is she has multiple sites in her NCORP. So there only needs to be 4 oncologists. So can she put multiple sites together under one center?
Right.
And have 4 physicians?
Yeah. So actually, thanks, Diane, for bringing that up. Judy, is that, did you?
So we were thinking not, because the sites that we have all have separate CTEP IDs and they don't share EMRs. I mean, this is a separate site, 150 miles away. They don't share staff. They don't share coordinators. They're just under our NCORP. So if there's a way to do that, we're not aware. And really, I mean, I'm fine with talking about my own site offline on this meeting, but I thought as you were looking at the application, it may be a barrier to enrollment for other sites who have small sites out there with only maybe a couple of med-oncs, but sufficient volume that you might want to look at, is this a barrier in general to not just our site, but other sites out there?
Yeah, Judy, I think that's actually, again, that's a great comment, and we'll think about this, because my, current understanding is that we really only define who cannot, how should I say this? We define how, within one NCORP, when you cannot separate out, when you cannot combine, no, when you cannot separate out sites. But if I don't think there's any rules about combining sites. So I think that's something that that's the overarching question here. I think it's a really good one, actually. So we'll ponder this some more and get back to you and others. All right, are you good? Go ahead.
Yeah, a comment. Yeah, if this can't kind of be resolved, you're going to probably dilute some of the power of the study, because some of the more rural sites, if you just have 2 docs at a tumor board, are less likely to have that body of knowledge than a 4 or 5 oncologist site. So I'm thinking that you may have more luck showing a benefit if you are able to assist sites with less of kind of a fund of knowledge from multiple oncologists.
Yeah, thanks. For the ones on Zoom, that was Dr. Wilson. Thanks. No, thanks. That was a great, these are really good points. So thanks for bringing them up. And I've been sort of cruising through these slides, but Magna, I think there's a couple of other things on Zoom, but it's a little bit hard for me to monitor both. So if you see anything else that you think we should address, just do what you just did. That was great, actually.
No problem. I'll keep an eye on the chats.
Yes, keep an eye on the chat, and then and obviously at the end, so looking at the time, but we should have some time to discuss some more questions. I'll go relatively quickly. And my watch is talking to me in German. That's fantastic. All right.
I have one question.
Yes, please.
So do you think the increasing use of large panels, even for diseases that before they were just doing a couple of testing, so like EGFR and ALK and things like that, is that going to impact negatively on the success of your study? Will there be less impact of a genomic tumor board given the increased use of the large panels?
Yeah, that's actually a really good question. So I think when we designed, so we based our kind of effect size and power calculation on the data that we saw in Maine, where essentially what we did there, we actually just disseminated the testing to all we made it available free of charge to the patient. It was actually one of the grant covered activities that we had. So to your point, many more patients actually got tested there that, were beyond sort of the tier 1, scenarios, lung cancer, colon cancer, et cetera. So I think we'll be actually okay with this. And when you look at we've started analyzing some of the data as well, and it's really quite interesting. I mean, the majority of the work of a genomic tumor board really is to go through these non-standard markers and identify either a trial that's local or maybe even an off-label type therapy, right? And you'd be surprised, actually, it is, even in smaller practices, it is quite possible for patients to receive that type of therapy when it is, especially when it's backed up by evidence and so forth.
But are you still including? But you're still including more common therapies as well, correct? That's what I meant by diluting.
Yes.
In other words, let's say you're in a population that, let's just say you might have a lot of EGFR and ALK in lung in one population, and that might dilute your effect.
Got it. Okay.
That's what I was getting at. I'm sorry.
Yeah, no, that's a really good point. I would say, I would imagine that it's not going to be the majority of cases. And actually, even there, quite frankly, again, this is something that we really should think about, and actually observe directly as we go through the study as well, and sort of, consider tweaking. We can always think about, redesigning or redoing the design here if we really see such an effect. But it's actually quite surprising that some of the, if you have an exon 19 EGFR mutation, I think everyone kind of knows what to do with that. You don't really need a molecular tumor board, right? But it already gets more complicated when you get into the non-traditional EGFR mutations, for example. Or take MET, right? MET fusions, right, are actually on label. Amplifications, it's not on label, but it's in the guidelines, right? So I think there are still enough nuances and unclarities, even with the increasing number of FDA labels. That would be my sort of take on the current scenario. But again, that's also why it's important to follow the trends overall, because we might see a change, significant changes in just a 2-year time period for the study. So, all right. Oh, I messed with this again, so I have to go. There you go. Okay, so patient eligibility are really straightforward. There is a sort of kind of to some of the points that have been made potentially, but we're basically using, this is the current definition of who is eligible for genomic tumor testing under Medicare reimbursement rules. That's taken directly from the CMS website, and it's essentially congruent with what ASCO just came out with. All the other ones are fairly straightforward. Obviously, they are allowed to be co-enrolled in other clinical trials because it's not a treatment study. And the other point that's important is that the patient has to be enrolled after the test has been ordered, but before the results come back. And the reason for that is that we don't want any sort of bias in terms of which are the cases that go to a genomic tumor board and which ones don't. And also, quite frankly, it seems like this is a natural time point to think about study enrollment, as we've been, in some of the conversations that we've had, as we found out. So that's important to point out here. There are some, sort of removal from protocol criteria for the physicians. They are actually pretty straightforward. We can certainly talk about that more if there's question. Requirement for.
Oh, sorry. Can I just ask a question
yes,
about
please.
patients, the patient side of things?
Yes.
So Christina Merkopper, thoracic oncologist over at the Hutch. One question that I had on the patient side of things is, especially for your patients with like a newly diagnosed metastatic lung cancer, for example, we often run into these situations where patients are really quite highly symptomatic. And I was noticing that there can be up to a 2-week lag even between, receipt of the results and then discussion at the tumor board. Is there any sort of process in place for that situation, giving those physicians counseling on, what therapies could be started more urgently?
Yeah, that's a great question. So we actually have something built into the protocol. I didn't put it on the slide here, that if there are, cases can be fast tracked is essentially what we're writing in for situations like this. And so, yes, absolutely. So because I agree with you that sometimes you need to get the interpretation more quickly. And obviously we oftentimes say, and I'm sure you say this yourself all the time, it's better to make the right treatment plan rather than to make it quickly, right? But there are some situations where you don't have the luxury. So, and what we may also be able to do if we can't convene a full board, then there may be the opportunity to have sort of a kind of a fast track, sort of asynchronous, consult as well. So, thank you.
Thanks.
Good question. Let's go. There we go. Site registration. So this is really very technical, but you have to the form. There's a site form that needs to be filled out. It needs to go to CTSU, and the patients, the participants are registered and open. There's some technical details here. Physician registration, very similar. Happy to talk more about details, and there are others on the call who can speak to this much more knowledgeably than me. Yeah, I think the most important piece here is again about the 7-day window, and that it's prior to receiving the results. And there are some stipulations here. What happens when when that doesn't happen that way? Now, one thing here, and actually we have gotten a question about this. So let me just halt there for just a second. So we actually made the decision that advanced practice providers are not permitted to register patients to the study, primarily because, again, it's all about the treatment decision, which is, I think, in most instances around the country, is still made by physicians, even though that a nurse practitioner may see a patient quite frequently in follow-up, or even at the time of a treatment decision, but the decisions themselves are made by the treating physician. So if anyone has any concerns about that, happy to hear that again, but I think that's where we currently are. But I do know that there were some other studies discussed earlier today where this question has also come up. Here are some, we use metadata rave in terms of data submission, some details on what the source documentation is that we're going to require. It's all about the readable PDF format. We know that sometimes can be a challenge enough. Sometimes it's a photocopy of a fax that was faxed from somewhere else. And that certainly becomes very challenging. We'll obviously document the total number of unique patients that have GTT ordered, including the patients that are not registered to the study, again, just so that we know what the kind of the denominator is. I don't think we're going to go into this in much detail here, but this is just kind of I suppose the involvement or the burden on the physicians. There's a baseline survey, as I said. There is a kind of an end of study survey over here, and then for each patient that is associated with the physician, there will be a very brief survey to understand whether or not, and we are calling it, what are we calling it here? Genomic testing questionnaire, where we want to understand, genome informed therapy questionnaire, that's it. Where we want to understand whether or not, based on the physician's, in the physician's opinion, this was genome informed therapy. All right. Yes, for both groups, right. So we want, because the idea is also that we, obviously this will happen in the control group as well, right? And there you could expect that there is even a difference, right, potentially between the two groups in that. So yes, it's for both groups. Patient data is obviously it's a little bit more intense, but it's really all about data collection here in follow-up. And there has to be some, registration, there's an on-study form. There is data that actually goes to the GTB that comes out of the EDC system, the pathology, genomic tumor test report. And then we are going to ask to get fairly detailed treatment information. Now, when I say fairly detailed, what do I mean? I mean drug name, and we have a controlled vocabulary list, so that you don't have to, find the spelling of all these wonderful new drug names. And we'll ask for the first and the last day on treatment. We will not ask for doses. So that's, the one thing that we will not ask. All right, we'll have these monthly teleconferences, and these are for both the intervention and the usual care arm to really, assess how things are going in terms of recruitment, what are the barriers, and how, what else can we do to support enrollment primarily. We will have a physician champion, and we actually put some parameters into the protocol as to what the expectation is. We know that physician champions can't attend every one of these phone calls, but the expectation is that they will attend 50% of the calls over the course of the study. There is some, quality control issues that are listed here. Study monitoring. There is a data and safety monitoring committee, which will oversee the conduct of the trial. And, the majority, obviously, since it's not a treatment study, emphasis of this will be on accrual feasibility and any sort of contaminating factor in terms of patient enrollment and so forth. And this is sort of, this gets a little bit at one issue, of course, is we've actually already had a few conversations about this with some potential recruitment centers, that say, well, we do plan on having an intervention like this at our site or at our practice within the next year or so. Obviously no one can 100% predict the future. So in order to better understand what actually does happen at the arm, we also will monitor this. Are there all of a sudden EGTB and type interventions at one of the control arms and one of the control sites? And if so, we do need to know about it and account for it. Informed consent. I don't think there's anything. We will have Spanish translations. We had some questions about that. So primarily Spanish speaking patients can be enrolled. Oops, there we go. And this is one slide about the credits. So there is a credit here towards SWOG membership upon participant registration to the study. There are others that can answer this in more detail. Here is some, who can participate. And next steps. So we're actually, what's not on here, the protocol is currently undergoing IRB review. And so we're very close to having a final version 1, if you will. The recruitment center application will be available online within the next few weeks, and then we can get started essentially. We do want to acknowledge the Hope Foundation, and again, Dr. Ramsey, Dr. Hirschman, Dr. Unger, and the entire team really for working with us on this. I think it's been a very interesting experience for many of us because it is a fairly unusual study design. And so, but we look forward to enrolling now, and we have our contact information slide here. And so we have some time. Thank you for your attention. And we have some 6-7 minutes left for additional questions.
You may have covered it, but since a 24-month follow-up period, what if the patient progresses on the first recommended therapy? Do you give another opportunity? I would imagine the docs at my center would want to represent. Should they progress? Has that been thought of, or not?
That is a great question. So the protocol currently does not allow for representation at a GTB. That's a very interesting point, actually. And I think it would be challenging to build into this design. But it's certainly an interesting point. So we'll think about how to address that. Any other questions in the room? Magna, is there anything on Zoom?
There's been a few questions I'm just trying to answer in the chat box.
Okay.
I think I see Katie with her hand up. Katie wants to say or ask something.
Yeah, thank you. I have a question for the potential sites that are in attendance. We have a pretty tight registration window of 7 days to register patients, 7 days between when the genomic tumor test was ordered, and it has to be prior to when the results are received. How will you be able to incorporate that into your clinic workflow? How challenging is that going to be? What can we think about now to help make that work for you? I appreciate your feedback.
So I'm going to look around in the room that people are thinking. Anyone on the Zoom call that would like to answer that question? It's a very important one, feasibility of patient enrollment in that time frame. Any thoughts in the room? I'm just going to put you on the spot there.
It's tough, but I mean, you just have to couple it with the ordering of tests when the patient in the clinic. It's gonna hinder enrollment for sure. I mean, a 7-day window. I don't know if there's a way that the team could allow, registration with intent to order the panel, pre-registration or something like that, to kind of get the ball rolling. That would be a challenge for us, particularly if you miss it on the first visit and they're 30 miles away and can't afford gas money. They're not going to come back to get enrolled. So,
yeah.
We are allowing for remote consent. So hopefully that will be helpful for patients who are not consented on site. I think Samantha Wright wrote something in the chat box where they would run a report for when Foundation 1 was ordered and then work off of that. So I think it sounds like finding some way to link it, enrollment to the ordering of the test at that time is probably, it sounds like it works. If anyone else has other comments.
Yeah, let me actually just build off of that, Megnite, because I think that was a really good point. So, talk to your favorite local test provider, actually, because the testing companies are becoming much more, helpful, I guess, in that context, and that they actually have, online portals and so forth. They can even, some companies can even run you reports of patients that were ordered at your practice. So that, and I agree that it's if it sort of becomes sort of part of the process, right? A test is not usually just ordered. I mean, clearly some clinics have, Epic, and they have some sort of genomic module integrated, and then you just go in and order it like any other test. But most of the time, and in most instances, there is a process involved, right? That there is someone else, someone within the care team actually fills out the form, or goes online or whatever it is, because oftentimes, the payment situation has to be clarified beforehand. There have to be prior auths done and so forth. So there is actually sort of that natural pause anyway. And if one can link it directly to that time point, that would be ideal. But I certainly hear the concern. So the question of the intent to order the test, I think, is going to be a little tricky, because then you may not actually end up doing it, right? And then you have a patient enrolled on study that doesn't really have anything that would support that. So that's a little bit of an issue. But so Dan, you were saying they can't be canceled. The enrollment can't be canceled, right? Or yeah. Yeah.
Dr. Reuter, this is Katie again. I'm wondering, when can the patients be consented? Surely, like, doing it after the test is ordered is pretty crazy tight. But if the patients are consented prior to the test, and I'm not sure if Patricia is on to address this directly, but it seemed that would be helpful for the workflows.
So you mean you could allow for consent, and then obviously registration comes after consent, right? So you could allow for consent before, and then, I mean, that's a thought. Yeah.
Yeah, we'd probably need to verify with Patricia, just make sure that's.
Yeah, Diane is getting up, so maybe she has.
Oh, good.
Okay, so Katie, yeah, we probably need to verify with Patricia, but what Elaine Armstrong has always said is a patient can be consented before registration. So you could do that. And she usually says you want to make sure it's less than like 30 days. You know, between consent and registration. Of course, you want to make that window as small as you can because, you know, they might change their mind or you never know. But that usually is an option for our studies.
Yeah.
Yeah, there are two comments in the chat box that seem to favor that. So I guess we should ask Patricia and make sure that that's something that we can do for this study.
Yeah. Checking my time here. Oh, it's 3 o'clock on the dot. So any last thoughts? Okay, well then I thank everyone for coming in person and for dialing into the Zoom, and we look forward to working with all of you. Thanks so much.